Thank you very much for the kind introduction. Thank you for the invitation to talk to you today about what I think is really becoming an exciting advance now in chronic lymphocytic leukemia, that we can start moving towards targeted therapy. Let's see. Here are my disclosures. So chronic lymphocytic leukemia is characterized by the accumulation of mature clonal B cells in the blood, lymph node, and bone marrow. It has Okay, I hope I'll figure this out by the end. So it's diagnosed with this classic immune phenotype, CD5 positive B cells. And the standard of care today is really chemoimmunotherapy, at least for younger patients, often as rituximab, fludarabine, and Cytoxan, as shown here from the randomized study that showed that rituximab improves the response rate from 22% for just combination chemotherapy to 44%, and the median progression-free survival with FCR in this series was 52 months. Still, CLL is probably incurable for the majority of patients with this approach. But notably, a select group of patients can have minimal residual disease negative remissions that last for 10 plus years. So maybe there is actually even a subset of CLL that's really cured with chemoimmunotherapy. But there are important limitations to FCR. One is it's clearly less effective for CLL with the deletion of chromosome band 17p, where patients only have a median progression-free survival of less than 1 year, less than 12 months. It's also less tolerable in elderly and frail patients. So ideally, we would like to have a more disease-directed agent that's tolerable and active. So how do you get to targeted therapy? Well, in many instances, it's actually been through understanding the genetic lesion of the disease, and the mutation, or in CML, the translocation has pointed the way. And even so, there are now probably a couple hundred CLL genomes sequenced and mutations are found. There is no clear disease-causing mutation, and most of the mutations are found, the frequent ones, are found in 10% or less of the patients. So the genetic analysis so far has not indicated a clear target for therapy. However, one understanding that has come out of decades of work more on a cell biology basis have shown us that CLL is a tumor that is addicted to the host. What I mean with that is that even though the CLL cells in the patient are apoptosis resistant, once you take them out of the patient, you put them in a culture dish, they actually rapidly die, unless one provides surrogates of what these cells encounter in the body. These surrogates can be cytokines, chemokines, other cells, or activation of cell surface molecules. And in this review here summarizes about 2 decades plus of work on this particular aspect of biology. And if you look at the list, it's really long and it's really diverse. So it looks like these cells, they basically make do with whatever they get. So it's an opportunistic tumor, which then would actually be very hard to approach with a targeted agent. So a little bit out of the confusion of this long list and just seeing all of this and wondering, well, is that what's really happening in the body, or is there maybe a first among equals, a predominant pathway that really drives the disease? So out of this question, we ask patients in our clinic, we ask 24 treatment-naive patients to donate blood, bone marrow, and lymph node for molecular analysis. And we purified the CLL cells out of these different tissues, made RNA, and put them on microarrays to globally characterize the gene expression profiles in these cells. And what we found, first of all, with 20,000 data points per sample, is that location really matters. It's obvious on a Friday afternoon in sunny Portland, location matters. But if you think about it, if you take a tumor cell from 3 different anatomic sites in the body, is it really that obvious that the tumor is different in every site? So we were actually quite intrigued by this finding, and obviously we followed up on what drives this difference. And what we found is that these cells show evidence for activation of the B cell receptor. So all mature B cells, as CLL cells are, express the B cell receptor on their surface. And we had 2 lines of evidence telling us that in the lymph node, this pathway is activated. One evidence is shown on the left, this heat map, showing you expression of target genes, of genes regulated by the pathway, highly expressed in the lymph nodes. All the red squares are a gene in a sample, highly expressed in the lymph node, low in the peripheral blood. And we confirmed this also by flow cytometry, looking at one of the upstream kinases in the pathway, the Syk tyrosine kinase, which was phosphorylated in the lymph node cells, but not in the peripheral blood cells. So both these lines of evidence then tell us really in the lymph node we get activation of the B cell receptor. And this is probably not happening in isolation, but it's happening in the context of a microenvironment, other cells, cytokines. So several of the other factors may play a role here. But I think the dominant event seems to be that the cells signal through the B cell receptor, which is actually the key pathway for mature B cells. And what it results in is activation of also the NF-kappa B pathway. It drives proliferation, and all these changes were more prominent in cells that, from patients with a more aggressive, more progressive subtype of the disease. Out of our analysis, we're actually not sure what role the bone marrow plays. The cells in the bone marrow and the blood were both pretty resting cells, whilst the cells in the lymph node are activated and proliferate. Okay, so I think we, out of this study, encouraged also by a lot of other studies and some evidence that's been building over decades in understanding CLL, we can hypothesize that if we hit the B cell receptor, we really get to a spot in the disease biology that is essential. And so this then could set the stage to replicate the success that imatinib has brought to chronic myelogenous leukemia. And while we're more than a decade behind imatinib with these advances in CLL, we immediately actually are blessed with a number of small molecule inhibitors that can effectively target this pathway. Let me just dwell on the pathway for a second. So when B cell receptor is activated through binding of antigen, it activates a signal transduction cascade consisting of kinases and adapter molecules. Among those kinases, Syk, PI3K delta, and BTK are essential, meaning if in mice these are removed, the mice don't have any mature B cells. There's no way these B cells can react to antigen. And these 3 kinases are the targets of small molecule inhibitors, idelalisib, the inhibitor of PI3K delta, and ibrutinib, the inhibitor of Bruton's tyrosine kinase, are now FDA approved for CLL and various forms of non-Hodgkin's lymphoma. I listed the several other kinase inhibitors that are in clinical development to really show you the breadth of this development. So we're not depending on just one inhibitor. There's a whole class. So ibrutinib is this inhibitor of Bruton's tyrosine kinase. It was discovered by Celera. Initially, they did a screen to look for kinase inhibitors for autoimmune and inflammatory diseases. They found this oral agent, so it's rapidly absorbed after oral dosing, has a short half-life, but it covalently binds a cysteine residue in BTK, leading to an irreversible inhibition of the enzyme, and this allows once daily drug administration. In the phase 1 trial, no maximum tolerated dose was established, and activity was seen across several entities of non-Hodgkin lymphomas and prominently in CLL. Phase 2 studies were initiated to follow up on this, and here's a summary of one of these, of the phase 1, phase 2 study, summarizing the responses. What you'll see, it starts at 2 months. Already at 2 months on an oral agent, once daily dosing, a substantial part of the patients have responded. However, the responses are slightly different than what we used to characterize responses in CLL, because all of these drugs lead to an initial rise in the lymphocyte count, which subsides gradually over time, and I'll get back to that. So this is this response category in yellow. Partial response was lymphocytosis, but these patients usually have dramatic shrinkage of lymph nodes and do feel better. And with time, as treatment continues, the lymphocytosis resolves, and